Good afternoon. Just want to say gracias, thank you to Drs. Mays, West, and Smith for inviting AAMC to join in this important effort. If you're not familiar, AAMC represents the MD granting institutions across the United States, Canada, as well as Puerto Rico. And yes, Puerto Rico is part of the United States and they're US citizens, okay? I have to say. So I'm here to talk a little bit with you about some of the work that we've been doing around the representation of men of color within medicine. So I'll start with the Summer Health Professions Education Program. Some of you may be familiar. As Dr. West mentioned, we've had a long-standing partnership with the American Dental Education Association to support this program, funded by the Robert Wood Johnson Foundation. And it's incredible because they've been funding this program for over 30 years, really looking at increasing the representation of Latinos, African Americans, American Indians, and Alaska Natives, students who are economically disadvantaged and have other educational disadvantages across the nation. To date, it's served nearly 30,000 young people aspiring to become health professionals. And we have some incredible data showing that at least 65% of these students apply to medical school, nearly 70% apply to dental school, and many more have pursued PhDs, MD degrees, degrees in law, education, and other areas. So we know that these programs are very critical in terms of the pathway to the health professions and other careers. At the same time, while these programs are very important or essential, they're not sufficient, and we can tell that by the data. When looking at SHPEP, we were recognizing, and SMDP actually, we were recognizing that the number of young men was beginning to decrease each year from 1% to 2%. And we recognized that we couldn't let this happen. So it was almost like an early indicator for us because SHPEP attracts freshman and sophomore college students. And what's critical about it is that we are always looking at the data. And I would say, and I would implore all of you, as you're looking at your systems, as you're looking at your institutions, let the data guide you because the data is going to give you really important information about what's happened, what is happening, and what needs to change. And so for us, we recognize that the young men were beginning to decline from 40 to 38 to 36%, and we're like, this is a problem, right? And again, it's an early indicator because we're looking at college students. And so we decided that we wanted to take a little bit more of a strategic approach to the engagement of young men. At the medical schools, and I'm sure at dental schools as well, you can be passive recipients of your application pools, right? You don't really have to do much because a lot of people aspire to become physicians or dentists or to enter other health professions. And we recognize that we cannot just sit back and wait for individuals to come to us, that we really have to be strategic in our communications and our outreach. And so what we decided to do is really look at our, for example, collateral material. What are the materials communicating? We recognize that even the pictures within our brochures on our website often didn't have young men, right? So if you don't see yourself visually in a place, you may question, do I really belong there? We decided to say, we need to have more direct communication. What are the testimonials that we could put together of men who communicate about the impact of these programs, the benefits of the programs, and how other men need to be engaged and to enter the health professions. As well, what we find is important that we can't do it alone. I love that concept of the and, not the or. And that's why we're here today with you, because we know that although our focus is on medicine, we can't do this alone, because the reality is all of us need men to be part of our health professions. And those strategic partnerships are critical. So not only working with undergraduate institutions, working with fraternal organizations, working with youth development organizations, looking at the community level, right? Because many of our institutions are anchor institutions, and we have to give back to our communities. Many of our institutions say, oh, I can't find the men. You can't now say you can't find them. You have to be part of the solution to build those young men, right? To bring them, to attract them, make them feel like they belong. And those are some of the things we've tried to do with our program, including having a committee dedicated to engaging young men from all communities. And what we found is these various strategies have helped us to increase the applications and the matriculation by 3%. Now, I know that's small, but if you think across the nation, a program that serves nearly 1,000 students, that's good, right? But we cannot do it alone. And that's what's important for us. We have to break down those barriers across the health professions. Because even though Dr. Hrabowski said, we have to start in college, we know that early intervention is critical. We know that our public health, our public education systems are failing our young people, and as a result, they're not getting into our health systems. So that early engagement is critical, and we could do that together with all of our resources. So I want to talk a little bit of a case within medicine where we saw that there's a significant national crisis. And this is the case especially with our American Indian Alaska Native communities. There's a national crisis across the health professions. And what we saw that was in 1978, we had more men applying to medical school than we had in 2014. Again, we have more Black men entering medical school, applying and entering medical school in 1978 than we had in 2014. So again, the data said, even though many of our members told us we're not seeing the Black men, we're not seeing the applicants, we're not seeing everyone, the data was kind of a clarion call for us, right? And that's why the reports, as Dr. West mentioned, Slow to Change, is so critical for our efforts, because we need the data to drive what we're doing. And although since the release of the report, we've seen some increases, including this past year, we had 20.8% more men matriculating, Black men matriculating to medical school, we know that there's so much work to be done. And this has been named by NASM as a national crisis, right? We cannot rest on our laurels. And what we've done at the association is partner with the National Medical Association to create an action collaborative for Black men in medicine. And this is intended to be a coalition building framework for us to really look at systems change. Because as I mentioned before, while many programs like the Summer Health Professions Education Program is significant, it's made a difference. Many of you could speak to the pathway programs that you have at your institutions and how they make a difference. They're not sufficient, right? Because that's why we're here today. What we've done before is working, but it's not enough. And so for us, partnering with the National Medical Association, that's the largest association representing Black physicians, we are looking at what is it that we need to do together. So these are some of our goals. We don't want to reinvent the wheel. We want to look at replicable solutions. We already know what the problems are. Use the data to drive our action and work with key stakeholders along what we call the medical education continuum, which we see starting as early as elementary school, all the way through graduation, right? Because Dr. Collins mentioned, it's sometimes going to be hard getting through the health profession school as well. And so this is just a framework that we've started with. The AAMC and the NMA are what we call the backbone organization. So we are using the collective impact model in order to drive how we see change moving forward. And so we're gonna enlist action partners, many of you hopefully here, that are gonna work with us over time, because this is not just one-time solution, one program, one conversation. We really wanna come together to think about how do we begin to change. And these are some of our core members. We're working across the continuum with K through 12 teachers, with leaders who have done science on the experience of Black men in higher education. This is what we see as our kind of a storyboard, right? Starting, as I said early, K through 8, understanding what the data tells us already, what those gaps are. But we decided to say, let's work, because we can't handle everything right now. Let's focus on the last 2 years of high school through the first 2 to 3 years of medical school. What is it that we can do a deep dive to understand what the issues are? And again, systems-based interventions, we wanted to streamline our efforts and look at what's sustainable. And so this is the collective impact model that I mentioned, a backbone. You need leaders, you need drivers, you need individuals, organizations that are involved in systems like AAMC and ADEA to really begin to drive this, right, across the nation. Now, we can't do it alone, as I mentioned. Our organization is good at some part of this. Another organization could be maybe stronger in working with high school students. So those mutually reinforcing activities, how do we come together almost like pieces of a puzzle to solve this issue, right? So we're not duplicative, but we're looking at how we can coordinate our actions to really make change. continuous communication, always working with one another, sharing what we're doing right, what we learned was wrong. That continuous communication is critical, a common agenda, and that's what we're going to work on. We're going to identify as a coalition what are at least the top 2-3 priorities that we want to address over 5 to 7 years, recognizing that it takes time to make systems change and to be accountable, to have those shared metrics. So I'm hoping that as we have conversations here, each of you can think about, at my institution, at my organization, what is going to help me keep our leaders accountable for the change that we want to see? How are we going to measure that change over time? What is it that we want to see happen differently, and what is the data going to tell us at the end? And so these are some of our accomplishments, really. We've been together since 2020. And these are some factors. When we came together, we looked at the data, we looked at research, we examined lived experiences, because there is limited data on the experience of Black men, in particular in medicine. So we said, what about those lived experiences of leaders, learners across the continuum? And these are the factors that we identified that we feel are important to look at. Financing and funding, again, you need money, we need money. Because the reality is, when we think about Black men, Latino men, American Indian, Alaska Native men in particular, they're at the bottom of our economic ladder in the United States. We have to recognize that, right? Also, information access, MCAT, DAT, name whatever standardized test, right? And how we use the test in order to really begin to advance diversity in our institutions. How do we identify talent? And with all of this, and this was mentioned earlier, we have to recognize that there's systemic racism, there are public narratives that influence how we think about men of color, and we have to change our institutional culture and climate. So it's not only about increasing the number of individuals, but it's looking at our institution and our climate and changing. So all these things in concert are very necessary in order to make this change. And for us, within academic medicine, we realize there are factors that we cannot control, right? We cannot control the K-12 system. And unfortunately, many of our leaders say, well, that's not our thing, right? We're here in dental school. No, it is our thing. It is our responsibility. Because we're expecting, and it was funny how Dr. Kowalski mentioned, well, you give me the money, I'll produce them for you. Right? We rely on our undergraduate institutions to produce dentists, to produce physicians, to produce other health professions, but why would they do it? What's in it for them? We rely, many times we hear young people say, I don't have a pre-health advisor, that pre-health advisor wasn't any good, or I didn't have access. We're relying on a broken system. There's no system for pre-health advising. They don't even have standardized training. This is much of what we've learned about what are the systems factors that are concerns, but what are some facilitating factors as well? We've heard so much about support systems, mentoring. Those are systems issues, right? It's not a person level issue. So how do we begin to intervene? And so this is one example that the committee decided, collaborated to focus on pre-med advising, pre-health advising, identifying again, there's no formal training, but yet we rely on them. Right? We rely on these individuals that often aren't trained, that in many cases, the institutions where we need to go, they're not formal positions, they're faculty, often in the sciences who've never been dentists or physicians or other health professions to advise students. So there's so much work that we could do as associations, as institutions, as organizations to really change this. And this is our proposed roadmap. We have an online community. We're going to be building our strategy over time to then look at how each organization, institution that's committed to this is going to move the needle, right? And what are our metrics along the way so we can learn from that experience and think about and know what works. And so these are some partner organizations that we are focused on. And if you want to learn more, please join us. And this is part of it. This is part of being here, being together for us to build our capacity as leaders to make change. So thank you.